afternoon and welcome to my YouTube session. This is Morgan Abike Doctor. So what I'm going to do is I'm going to present on the management of pain. So to start with, I will start with the introduction of what are pains. So pains, in a nutshell, a pain is one of the most severe injuries of a person can suffer. Like for example, in here there is India there, but we're using Zambia. Yes. So in Zambia, pains are most commonly in poor people, especially those people that have got their apartment or their shelter is not properly built. So sometimes maybe it can catch fines, so on and so forth. So pains are more common in poor people due to the overcrowding. And then one store, you realize that when there is overcrowding, then these people are using one store. So if that house catches fire, then it creates a problem. The flow, then we also have the flow where you find to say that the level of cooking maybe just on the floor, and also those that have got poor housing planning. So even this one can be the major cause of pain. So in fact, pain injury can be classified as a chronic disease. It can be classified as a chronic disease as it requires long-term management. So when it gets into chronic, meaning that it is going to require a long-term management. It needs supervision as well as rehabilitation and also psychosocial support. Alright, okay. So the definition for a burn is this is how we define a burn. A burn is a tissue injury that results from the thermal application. So the thermal application here is we are using one hot, like it's temperature, something that is hot, that is fire. Yes, so it can either be hot or cold, and from application of physical or chemical energy. So when we talk about physical, meaning that maybe someone has been burnt, that is physical. Yeah, that is physical. And besides that, then you realize that burns are caused by dry heat, and the moist heat, as well as the cold injuries and the chemical burns. Then also the electrical burns. Electrical burns, these are burns that are done by the electrical energy. Ionization, radiation. This one is done maybe when someone is using, especially those radiographers, the one that use X-rays and those nuclear radiation. Because under radiation there we have what we call the random spontaneous disintegration of those radioactive nuclear sample. It can cause injury on your skin, alright, and they can cause some skin dermatoid and so on and so forth. Then under burns we have what we call, it also causes friction. Okay, now incidence of burns in our country, and I realize that especially in those places where it is highly crowded, you realize that the incidence of burn injuries are there, but the exact figures of incidence, they are not necessarily a variable. But the largest group of patients suffering from burns are children and young women. You know, young women, they are the one that prepares the food, cooking and so on and so forth. So the moment she gets stressed, then she can forget and just burn herself. Okay, even children, let's say for example, if they are playing around fire, they can cause physical injury on their skin. Okay, then what are the diagnostic criteria for burns? So these are the diagnostic material for burns that we use. Okay, number one, we consider history. So under history, on the M's here, we look at the time of burn. What time was this person going to burn? Like what time was the incident occurred? Then the possibility of being a meteor-legal case. Is it a medical legal case, or maybe someone was, for example, if let's say if it was intentional, or sometimes maybe it just happened, you realize that when you go to the hospital, they'll request for the medical legal document where you have to go and then report what had happened. Then it becomes a medical legal case. Yeah. Then example of history can either be someone having RHs, someone having maybe meditation, the past medical history. Maybe someone had some past. You know, sometimes how pains is, it makes you to have that anxiety where you're living life as if maybe someone is threatening you, especially if you got involved in this pain injury, because how they come as a result of maybe you've been traumatized. Yes. And also maybe last meal when you're cooking, you were so tired, you were too tired. Okay, so even that one can be part of the history under diagnostic criteria. And also the event of the environment of the burn injury, where it is. Then the other one that we can look at is the physical examination and the evaluation of the burn wound. So under this one, this is where we look at the grade, we look at the degree of burns. So in here, we look at the degree of burn, where we have to focus on the depth of the burn. And then from there, we realize to say that there is, let me just get my lighter. Yes, there is the first degree of burn, where the minor epithelium becomes damaged and then they will present something that is a redness. Remember, the clinical signs and symptoms for inflammation, sometimes it presents redness, excuse me, and the clinically insignificant, and so on and so forth. Okay. Then the second degree of burn, this one is partial thickness, the partial thickness and burn scat. And these are very painful because you see the skin peeling off and so on and so forth. Then the third degree of burn, this one it is a full thickness burn, and it is usually painless, because this one, yeah, it's usually painless. Okay. Now, how do we do the calculation on the surface of the surface area of burn? This is how we do the calculation on the surface area of the burn. We consider what we call dermatodes. So we consider what we call dermatodes. Okay. So using the Lorentz rule of 9 is used if we in adult and children. We use the land as well as the breeder's chart that can be used. Then we can also use what we call the rough guide, which is the surface area for the palm, which is approximately about 1% of the total body surface. That is the TBSA. So this is what we do. We consider the areas, the body areas. So these are the dermatodes. You check on the limbs, the upper limbs, the lower limbs. You check which part was affected the most, and so on and so forth. Okay. Then, what are some of the admission criteria that we use for referral? Sometimes we want to refer a patient. So number one, we consider maybe 100 or more bedded hospital, or a burn center. Like all major burns, like we have the partial thickness of the burn, which is greater than 25% of the total body surface area burnt for an adult. Then we've got those other burns which are greater than 20% burnt in children below 10 years, and adults which are greater than 50 years, and so on and so forth. Then you also consider the thickness of the burn. Is it 10%? Is it greater than 10% of the total body surface area? Or you also take into consideration the burn of the face. You check the face, the eyes, the ears, as well as the perineum. So you check all these surface, and then these are the very cardinal important that you need to take note of. Then the chemical burn. So chemical burn as well as the electrical burn. Inhalation, like inhalational injury, for example, if it's a chemical, you inhale it, it can cause injury in your cells, like your internal cells, the epithelial, it can damage the epithelial cells, and so on and so forth. Also the underlying deliberating illnesses. Okay. Then again, the other thing that we need to take note of is maybe if we have 30 to 100 bedded community healthcare center. This is just a community. Maybe it has got the hospital which has got about 30 to 100 bedded community health center. So this one, it becomes more moderate burn, like greater than 15% of the total body surface area, including the burn described above. Okay. So now, how do we do the management of burn? Okay. So management of burns is though the examination of the burn patient for the presence of the injury is essential as per primary survey of the protocol. So if any life-threatening condition found, for example, if someone is threatening you, that also can either be another predisposing factor that can make one to land in such kind of a situation. So it may be it may be attended to simultaneously. So it can be attended to simultaneously. Then the other thing that we need to take note of, to take a look at, is the management of specific major burns. Like you check the airways. You check the airways. This is the airway. Was it burned? For example, if someone maybe took some smoke inhalation syndrome, you see you see some burn on their face and the neck and the laryngeal. They might have what we call laryngeal edema, which is just a swelling. That may need intubation, or it may need tracheotomy. What is tracheotomy? Tracheotomy is the surgical incision of the trachea, where you do some incision in the trachea. Then, for example, oxygen inhalation. So under oxygen inhalation here, for example, if it has started at 8 to 12 liters per minute in a patient having dyspnea. So dyspnea, this is a condition where you realize that this patient has got some difficulties even in breathing because of the pains that has affected the respiratory tract. So they cannot inhale the oxygen properly. Then the major burns are the airway burns and the smoke inhalation syndrome. Okay. Then the other one is fluid resuscitation. You have to check for the fluid resuscitation, like how much fluid was lost in 24 hours for someone who had some burns. Like incision of the large bowel cannula, or you cut down. The cut downs are necessary. Like for example, where we have the Parkland formula to be used for the calculation of the fluid required in the first 24 hours. That is, for example, if you have 4 milligrams per kg, so 4 milligrams per kg of burns, so we use the 4 milligrams of 4 milligrams burn per kg, so per kg. So that one, 4 milligrams per kg. This one is a fluid that is used where you get the fluid of choice, and then you get the the rinse ractet, and 50% of the fluid is to be transfused in the first 8 hours of the time of burn, from the time of burn, and the remaining 50% in the next 16 hours after resuscitation and someone at least is stabilizing. Then you need to be monitored by the vital parameters, the urine output, which should be 0.5 to 1 milliliter per kg per hour of urine output, and if it's below 0.5 mils per kg and per hour, and the bolus of 10 milligrams per kg, you have to check all those things. And then if the urine output is in excess, like for example if it is 2 mils per kg, 2 mils per kg per hour, so the rate of infusion should be reduced. So we're going to do a simple calculation. Okay, let me just pause it.